Just giving it a few seconds while people join in. All right, so hello everyone, and thanks for joining Smarter Coding, Stronger Revenue with IMO Health in NextGen. My name is Jordan Leifitz. I'm part of the marketing team here at IMO Health. A few housekeeping items before our speakers get started. We are fully recording this, so it will be sent to you later in the week. Just be on the lookout in your inbox. If you have any questions throughout the webinar, just type them into that Q&A chat box in your Zoom console, and then we'll do a live Q&A after our speakers are done. Today we have my two lovely colleagues, Dr. Deepak Pillai, he is a physician informaticist, and Josephine Carson, she's our Director of Client Success and Support. So without further ado, I'm going to pass it on over to Dr. Pillai.
Hi everyone, thank you very much for coming. Today we're going to talk about two broad topics, if you will. One leads into the other. At the end of it all, we hope you'll take away a few key learning points, if you will. First of all, as you see here on the slide, we all know the role of diagnosis capture and the role that has obviously for clinical documentation and downstream revenue cycles. But I hope you'll take away the importance of precision and specificity of diagnosis capture. I hope you'll also be able to take away how you can do this easily in NextGen. I hope you'll learn, in provider organizations around the country, clinical needs for documentation and billing and downstream needs are often not completely in sync necessarily. But I hope you'll learn that that doesn't have to be the case, that we can provide seamless solutions that meet the need for both communities, if you will, simultaneously. And then we'll also close on how we can impact reimbursement from a terminology perspective with some very simple workflow changes on the front end, not even changes, like quick tweaks is a better expression, that can help avoid denials and improve downstream workflow efficiencies like queries and so forth. Before we get started, we'll maybe begin with a poll question.
All right, so now we're going to ask you a quick poll question. So what is your biggest priority in your role right now? Is it strengthening reimbursement and reducing denials, reducing clinician documentation and an administrative burden, enhancing collaboration between clinical and billing teams, or implementing smarter EHR tools to support documentation workflows? So I'll give it a few more seconds and then we'll close out. All right, so it really seems like people are focused on strengthening reimbursement and reducing denials, and then also implementing smarter EHR tools. So that makes sense for us.
Right. Thank you, folks, for that feedback. That helps give context to those learning objectives that I more broadly discussed. So we'll be sure to touch on those points as well as we go through. Just to set the table, I should say, for all of us who are on the webinar today, a little bit about who we are. We've been around, IMO Health has been around since the mid-1990s, and we've been working on terminology for quite some time. We have hundreds of employees, many of whom are informaticists and physician informaticists like myself, terminologists, former healthcare executives, and so forth. Of all the stats we often like to quote here at IMO Health, probably the one that I'm most proud about is what you see in the upper right corner. And nearly all of U.S. healthcare utilizes IMO Health as their trusted content provider, in addition to a variety of workflow solutions, one of which we'll be talking about today. So with that huge footprint, we often get the question, hey, yeah, we have IMO, but what do you guys do exactly? And to that, I often think we're often under the hood, if you will, working within the EHR experience. So I often answer that with the two words you see highlighted on the left. Clinical, at our foundation, we're clinical terminology. We provide terms or dictionaries that allow clinicians to say what they want to say clinically, not be limited to a reference or standardized code sets like SNOMED and ICD, which certainly have their role, but as you may know, often lack the clinical nuance that's needed for clinical needs. We provide clinical language and terminology that fits at that intersection to allow clinicians to say what they want to say on the front end, map it to all of the code sets that then drive the data ecosystem downstream. And as you can see by the infographic, then whatever the provider gets to say what they want to say clinically, and all the various use cases based on that standardized content and structured data can then work that much better. And it's something I'm personally passionate about, is that good clinical data on the front end makes the overall EHR experience better. Whether we're talking about decision support, provider notes, billing, certainly, regulatory reporting, and so forth. Next slide. Folks, a little look under the hood, if you will, about how we do this. You can look at the graphic here. You can see how ICD and SNOMED, for example, have gaps in their coverage, or perhaps not the full breadth of coverage of clinical expressions, I should say. If you look at the green IMO Health column, we essentially, like I said earlier, create dictionaries that span the entire complement of clinical expression. Over 375,000 distinct clinical concepts representing, and that's just with our problem and diagnosis domain alone, representing something like 1.3 million terms. We do something similar for procedure, allergens, lab data, et cetera. All in all, approximately 5 million different expressions. And if you look at our problem domain, the size of these boxes, if you will, represent an illustration of the level of granularity of these terms. So sometimes we'll create more general terms in SNOMED and ICD. Like we might have an expression, if you consider the first bar to be unspecified pneumonia, because clinically, we don't often know the causative organism when a patient's disposition needs to be determined. And yet, and so having to sort through all of the ICD expressions of what caused the pneumonia is clinically inappropriate because you don't always have the cultures back, for example. So we'll create general expressions to meet that clinical need, map it to all the standard code sets in the background. So where we hang our hat, of course, are all those small little boxes you see in the green column. The highly specific and granular, precise clinical expression that can't be captured by a single SNOMED and ICD code. So, for example, breast carcinoma, stage 3 breast carcinoma with estrogen receptor positive nodes. That means something clinically, but there is no way you can capture that with a single ICD or SNOMED code. So that's a little bit about who we are, what we do, and a little bit about how we do it. I'd like to drive it home now with a couple of examples. We'll start with a simple one, and then I'll really step on the gas with a powerful, complex example and how we make that easy. The simple one is heart attack, or in this case, STEMI. It's been a while, but when I looked at it a while ago, I think there was over 40 different ways to capture this expression. All for, clinically, I should say, all for good reason, right? Where a provider gets trained, regional, geographic difference. Even the patient's clinical presentation for that encounter in that moment often dictates the nuance of a term that a provider wants to capture in a structured field in the EHR. We want to allow for that variation on the front end, but the IMO Health expression comes along with all of the codes that are associated with that. whether it's ICD, SNOMED, or a multitude of international codes. So the provider doesn't have to remember the single one way ICD happens to express that condition. Simple example on the next slide. We'll talk about, I'll illustrate this with a much more complex example that has revenue cycle implications as well, or reimbursement implications, I should say. Let's take another breast cancer example here. This is breast cancer with pelvic met. As you can see on the left, there's not a single SNOMED code or even a single ICD code that can express that simple clinical expression. With SNOMED, for example, it comes with 3 different codes. One to capture the general carcinoma of the breast, the other one to capture the primary malignancy, another one to capture the anatomic site to which it has metastasized to. Similar idea with the ICD codes. So if you don't have clinical terminology in say the problem list, and you're trying to capture in a discrete data field on the problem list, this patient's breast cancer, I'm not going to have time to go in 3 different ways to say it. I'm just going to find the closest best match. And if I don't have clinical terminology to say I have SNOMED, in the center column at the top, I'll pick the closest best match, primary breast cancer, and move on with my day. And when that propagates downstream to a billing code, for example, on a given encounter, the closest I could get is a single ICD code. But with clinical terminology, if you look in the middle column at the bottom, you'll have the clinical terminology expression, exactly what I want to say, breast cancer with pelvic met. And then if you look on the right, you'll get, when that propagates downstream, you get all of the ICD codes that come with that term. So say I put that on today's encounter, it propagates into ICD codes for billable purposes. You'll notice the risk factor. If this patient is part of a risk-based reimbursement model in terms of reimbursement, that RAF score goes up from 0.14 to over 2.6. That has implications, sometimes thousands of dollars on a single condition, on a single patient. And for what it's worth, even if it's a volume-based reimbursement model, specificity matters. And in this case, you get the fully specified condition with all of its codes that come with that. And all I've done as a provider is capture the clinical expression, because I know that what's going on with the patient. I don't have to worry about code. Next slide. So to summarize, the role of what we're solving for at IMO Health is the problem that clinical data has and the downstream consequences of that. Data is not friendly without interface terminology, and downstream that has revenue impact, revenue cycle impact, which we're talking about today, but workflow challenges too. Being, when I get queried days and weeks down the road, long after I remembered that encounter, to make one little tweak, and all of the inefficiencies that come with that. That's just one small example of that. Next slide. So what we solve for is to create solutions that are not just content, the databases and the dictionaries that I've been talking about, but the way in which we can deliver that to users through various EHR channels, if you will, to help solve for those problems and make the entire data ecosystem more efficient. And so to that point, the experience of IMO is often unique for every environment, and rightfully so, because we want your experience to be seamless and not be disjointed from your provider's experience already in that EHR. So we'll shift gears now and talk about how we bring this to life in NextGen. Yeah.
Great, thanks, Dr. Pillai. Let me go ahead and share one more screen. Okay, that looks good. Just a thumbs up. That looks okay. Great, thank you. So what I'll be showing today is our newest IMO core version for NextGen. If any of you were at NextGen UGM just the other week, we were showcasing this a lot as well at our booth. Thanks again for joining us to take a look at what we've been working on. So for some background on the evolution of our IMO core product, we've historically always built our platform using NextGen's template editor tools. We've really maxed out our capabilities on what we can introduce to the template without impacting performance. Therefore, we've rebuilt the solution to now be fully integrated with NextGen's APIs. This allows you to really be able to utilize all the solutions that we deliver to IMO Core and have a much more performant product and work much more smoothly within your EHR. This new version now functions as a medical records pop-up. So what you can do is still launch it from all the areas of EHR that you're used to utilizing IMO, such as SOAP. I first want to highlight the search and capture capabilities for adding a new diagnosis to today's assessments. I know a lot of you on this webinar are already familiar with this function, as this really has been a function we've always delivered to our NextGen clients since the very start of our partnership with NextGen. And this is the ability to easily search and capture a diagnosis for today's assessment list, and also be navigated to the highest level of specificity when needed. So right within this assessment window, I'll make a search for something like knee pain. The plus button here is what allows you to just add the diagnosis to the encounter. This little calculator icon is what will prompt you to specify further when the term needs to be refined further for ICD-10 guidelines. Once I finish that specificity and select the diagnosis, you'll notice that all the codes needed to fully represent acute pain of both knees is added to assessment. On the left side here, we're displaying the patient's chronic problem list. So we're really bringing the problem list at the forefront now of IMO Core. You can easily resolve problems with one click by just pressing this check mark, which will resolve the problem record. You can also address problems for today's encounter. So if I click on CHF to address that for today, I want to move that to today's assessments. Notice how, because I'm moving this to today's assessments, which is then going to be billed on the claim, I'm now prompted to specify further. Since the problem list doesn't necessarily need ICD-10 specificity, very generic problems such as CHF could be on the problem list, but now I'm being prompted with what should get more specific. And now in this workflow, what I can do is at the very same time of adding to today's assessments, I can also update this existing problem so that now this more specific CHF is documented on the patient's problem list, and I won't be prompted with these questions again about specificity. So to improve clinical relevance and enhance better efficiency, we've now also introduced the ability to display medications and lab results associated with each problem condition. So when you click into a specific problem, that's where this detail will appear. So this really can reduce some clinical cognitive load for clinicians during the documentation process so that they don't need to navigate in multiple areas of EHR to find this information. Now, a lot of people are focused on Medicare Advantage these days and getting the right RAF scores for your Medicare Advantage patients. This is a huge and growing part of most of our clients' payer mix, which is coming from our clients' Medicare Advantage patients, which are reimbursed a bit differently. Instead of a fee for service, it's actually a fee for value model, which is helping to manage patients' chronic conditions and try to keep the cost of that care down by managing these conditions over time so they don't become more severe. So there are diagnoses part of that model that we flag here to let you know, also known as our HCC flags. We color code these flags with blue, meaning this condition has already been addressed in the current calendar year. It's not due to be addressed again. Orange indicates that this is an HCC and it actually has not yet been addressed in the current calendar year. To simplify that and give you a more single view of the HCC list and what truly is the unaddressed HCCs on the patient's chart, you can also just refer to this HCC list tab. And this will give you a clean picture of all the HCCs that are being flagged for this year to be addressed. So let's now go with diabetes. I want to address that for today. Again, I am prompted with very important things that should be specified for diabetes. You can't just state diabetes anymore, E11.9. So what we're bringing now to the forefront is what should be specified, since I'm moving this to the assessment list for today's encounter. And while we are asking for quite a few clicks during this workflow because there are lots of different codes associated with diabetes, these are important clicks because it's letting you get to the highest level of specificity. And once I do that, like Dr. Pillai had mentioned earlier, every single one of these codes that just automatically came over carries a RAF. And that can just increase your reimbursement even more. And that is what automatically came over from walking through that workflow prompted by IMO. We're still supporting a favorites list in IMO Core. We know our users love their favorites list. And over time, we have really received a lot of feedback on how we can better improve the user-specific favorites in IMO Core. We know that you've been wanting a more organized favorites, and with this new version, we're now able to do that. So similar to what we do with the patient's clinical problem list by organizing the problem in its clinical specialty category, we're now doing the same thing in the favorites. So this gives you a much more organized view of your favorites, where each term will fall into its specific category. So if you're a primary care provider, you have a much more organized view of your favorites. If you're a specialist, you can hone in on those specific favorites that fall under your specialty. So now for what I am really, really excited about is our problem list cleanup tool. So lots of your problem lists are likely cluttered with problems that shouldn't be there anymore, such as appendicitis from 10 years ago or pregnancy from 5 years ago, also known as just noise on the problem list, making it harder to manage. We now have a tool to help you quickly clean up those conditions in bulk. Based on those acute conditions that are no longer active, we call those out in this cleanup tab. We identify duplicates such as lower back pain. We know that back pain lower is also already on the problem list, so we're suggesting that this one be cleaned up. We also, lots of times if a provider does not do a thorough review of what's already on the problem list, they can then be adding things that are redundant or duplicate without even realizing, and that can lead to a messy problem list. And that's why this cleanup solution can help quickly clean that up in bulk. We also find related problems that might not necessarily look like duplicates because the descriptions are different. One might be much more specific than the other, or there might actually be different ICD-10 mappings behind it. But we know from a clinical perspective that they are related. So we would suggest those types of conditions to be cleaned up as well. So we can make this much easier for you to clean up the problem list by just selecting this clean selected problems. And that will clean up everything we've pre-scratched out in bulk and also resolve all those conditions on the NextGen side as well. The related problems that we don't pre-select are because we believe it should be up to the clinician to make that decision on which one you want to keep and which one you would like to resolve from the problem list. So I can easily make that decision right here and resolve both of those in bulk. And I now have a clean problem list without redundancies, without acute conditions that are no longer relevant.
If I may add, Joe, a little color to that, what I've noticed around the country is that the clinical organization that you see on the left is a good first step to helping reduce clutter. But invariably, as providers engage with it, different specialists, different roles, different care settings, et cetera, they do unravel. And that's where the cleanup tool comes in really handy, because it makes it easy for any organization, based on your governance policies around problem list management, for those providers to easily see where the clutter has grown out and clean it up with a few simple clicks.
Thank you. On the other side of that coin, we're also identifying what should be added to the problem list. And this is our suggested additions. So over time, we've spoken to clinicians who have shared feedback with us that they have patients with basically nothing on the problem list because the previous physician was not managing the problem list or in any way, or that current physician is just not managing it in any way and simply just doesn't have the time to. This list is going to prompt you with the chronic conditions that we're finding in the patient's history and that have been mentioned in a previous encounter at some point. And we call them out in this streamlined purview so that you can get an easy start on building that patient's problem list and documenting the conditions that should be there on the problem list. You'll notice that some of these are HCCs as well. So this can really help impact your reimbursement. Once this is documented on the problem list, within IMO Core, we're going to keep tracking it year over year for you and let you know when it's time to address that condition. So to accept one of these suggestions and add it to the problem list, I can simply just press this add button, and that now becomes an active problem on this patient's problem list. If there was anything you want to dismiss, the patient maybe no longer has that condition, it's resolved, it shouldn't be on the problem list, you can dismiss that suggestion and that will actually go away. We won't suggest it again. All right, and then the last piece that I'm actually unable to live demo because it's currently in development, but I am able to show with screenshots, so bear with me while I share my screen one more time. Okay. All right. Can you, oh, no, you can't see that.
You're
Good to go?
Yep.
Okay, wonderful. Thank you. So one thing that we know is that a significant, and based on actually the poll questions that you all answered earlier, One thing that we know is that a significant amount of time and resources is spent on correcting codes, resubmitting claims, or needing to go and get more details from the clinician after the encounter is already finalized. We know that this can lead to loss of revenue due to write-offs, and a high volume of denied claims is due to two main factors. Unacceptable principal diagnoses, meaning that a diagnosis code on the assessment list was incorrectly placed in a primary position, or unspecified codes, such as unspecified laterality on that diagnosis. So to improve your coding accuracy and reduce the amount of times you need to resubmit a claim or wait for a clinician to go back and make a correction maybe 6 weeks later, we're now letting you know at the point of care what should be corrected. So anyone with this new version of IMO Core will now get a check codes function right within the IMO Core workflow. And this is scheduled to be available right at the beginning of 2026. In this particular example, abscess of forearm was added to the patient's assessment list. That check codes function came in to do a check before being able to close out of IMO Core, and we're alerting that laterality failed to be specified, and suggesting that you edit that documentation, that diagnosis, to add laterality. So what you can do right within this same workflow is press the pencil icon and then change the term to include either left, right, or bilateral. And once all of your codes look good and you're good to go, a green check mark will appear. Another example is something that shouldn't be in a primary position. We're also going to check on that. So if there is something that is a manifestation, but not the actual underlying disease, we're going to suggest to add the underlying disease and make that the primary instead. And that,
Before,
go ahead.
I was just going to add from what we've seen around the country and when we've deployed this in other environments is that providers actually, and to pleasantly surprisingly, providers have taken to this pretty well, in that it is a suggestion, and that providers, I think it speaks to the fact that everybody wants to do the right thing, and there's recognition that reimbursement is critical to keeping the doors open for clinical care. And I think it's a great educational tool. In a very subtle way, physicians, providers across the board can very quickly and easily learn about the specificity that's needed to avoid these denials. And then they kind of develop the habit right up front to get that green check mark under the check code button. So it's a great, it's been adopted quite well when we've rolled this out into other environments.
All right. And I believe, Jordan, we have a poll question next.
Yes. All right. So if you direct your attention to the screen, so when do most coding errors occur in your workflow? Is it during documentation, incomplete or unclear notes, during code selection, limited specificity or guidance, during workflow handoffs, communication or process gaps, or during review or audit? Some missed errors get caught late. Give it a few more seconds. All right, it looks like during documentation and during code selection is the winner. All right.
I would say on that code selection piece, very understandable how that surfaced to the top in that poll question. And one of the benefits of the tool that Joe showed you and what I had talked about conceptually early on was that providers just need to pick what's clinically relevant. The codes come along almost like they come along for the ride. And so I think these clinically oriented tools like this, clinical documentation oriented tools like this, can really help resolve those type of issues.
Great. All right. And then, yeah, just some key takeaways from everything we discussed today. Coding matters. We know it does. Ease the load. So lean on our tools that we're delivering through IMO Core to really help just save clinician time and make it easier to document and stop revenue loss before it starts. So that's really, what our coding intelligence solution, that check codes function that I had shown, that's really what we're aiming to do and to help out with, is identifying those gaps right up front, right at the point of care, so that you don't have to go back and correct it later. And I think it's time for Q&A now.
Yeah, so we got quite a few questions that came in. Apologies if I mispronounced anything. Hold on one second. All right, so this one is referring to Z codes. So it says, for some ICD codes, especially Z codes, IMO provides a multitude of descriptions which are not similar, but are very varied by description. It has become difficult to choose the right Z code with the appropriate description that is used everywhere without any discrepancy. How can you help address this? They gave an example of Z71.89.
And I'll take that one. So it's a great question, and it's not an uncommon one at all. It stems from the fact that many codes, and you gave Z codes are a great general set of examples, where the codes are not as specific as the clinical documentation need. And so it really goes to the heart of what I was talking about at the beginning, where we might have a variety of different descriptions that match a particular clinical need, and we'll map it to the closest, most appropriate, most specific ICD code. Many cases, and these Z codes are an example of that, that level of specificity doesn't exist in the coding vernacular. And so we end up having to pick, by default, the same Z code for these. The solution is that the provider doesn't have to, the user, I should say, on the front end, doesn't have to worry about picking the right code, as I think is alluded to in the question. And it's a common habit that we all have, is I think I know my codes, I'm going to pick my right code. But really all they have to do is pick the right clinical expression for that need, and the code comes along regardless. So I would say it helps to change one's mindset, just focus on capturing the clinical intent. I hope that helps.
Great. Okay, what version is this?
Yeah, so this is IMO Core, our version. It's just our newest version that includes now our coding intelligence solution and problemless tool. So the version is still IMO Core.
And then when is this going to be released?
Great question. And I know we have been very excited about this, and it's been a long time coming with all of our efforts and development work and partnering with NextGen on this. Our account executives right now are actually doing reach outs to all of their individual clients to let you know now that this is available. So you should be expecting something from them very shortly if you haven't already.
Thank you. Deepak, I think this is related to what you just answered about Z codes, I'm assuming. It says, why not limit the number of descriptions to minimize the discrepancy?
Yeah, great question. And it's something we often think about, and we revisit this question often and regularly. The challenge is that a lot of times providers want to say things with a variety of different nuances and descriptions. And so we want to offer that variation on the front end. We at the same time, there are ways in which we're looking at and considering how, if things mean exactly the same thing, can we somehow collapse or merge the search results that show up and so forth. Those are always constant product development decisions that we're working on. But we always want to provide the ability to search in any multitude of ways that a provider wants to start with. How we feed those search results are something that's on our product considerations for the future.
Is there a user guide available?
Yes, absolutely. We have been finishing up our user guides with this new version, so there will be one available.
Okay, we'll be sure to send
Yep.
him that after. Okay, what version of NextGen can they use IMO Core on?
So this newest version, integrated with NextGen's APIs, can be used in 6.2021, can also be used in NG8, and it actually is compatible even down to 5.9.3, which I don't know if anyone is actually on 5.9.3 anymore. But if you are still on 6.2021 and have not yet upgraded to NG8, this version is still compatible with your version, with your EHR version.
Awesome. Okay, and then is there a cleanup in bulk for assessment and diagnosis list, or is there a similar cleanup? It might have been referring to something that you were talking about during the webinar, Deepak.
Yeah, I think it may be referring to when Joe was demonstrating our cleanup tool for chronic problems. I believe the question is there something similar for encounter-specific diagnosis lists? Assuming that's the case, then please correct me. The short answer is there is not.
Problem list cleanup. Yeah.
Oh yeah. So what was demonstrated is exactly for the chronic problem list. It's not offered for the encounter visit diagnoses because it from an informatics learning point, a visit diagnosis is always is cleared out after that encounter. It doesn't persist encounter to encounter. So the notion of a cleanup tool is only valid for a chronic list that spans multiple encounters. So yes, for the problem list, not necessary for the encounter list, visit diagnosis.
Okay, great. Josephine, this one's for you. How do code sets or terminology get managed within NextGen?
So within NextGen, you do have a separate NextGen library, also known as their diagnosis code library. That is updated manually by files that NextGen provides to you, that you would then go in and update, for example, during regulatory updates, when new ICD-10 codes are released. That is a library that you would need to update manually. On the IMO side of things, the actual IMO dictionary that you're looking up when searching terminology, that is all managed and maintained by IMO. So if there's any new terminology that we're releasing or any code updates, that's automatically released to you and available within the platform.
Great. Deepak, this probably is appropriate for you. Do these tools help with undercoding as well as overcoding?
Yes, absolutely. In both regards. Again, the notion of clinical terminology is such that a provider only needs to pick what's clinically relevant at the right level of specificity, of course, but what's clinically relevant. And so it's always appropriate for that patient scenario as long as they pick the right thing, and they don't have to worry about overcoding because they're picking what's clinically relevant. And by capturing specificity through those decision tree modifiers that Joe was showing you, you get to the right level of specificity, so you avoid the risk of undercoding. So it goes back to the notion of just say what you want to say clinically, the codes come along for the ride.
Got it. Joe, I missed a question, but can we see how it links in NextGen?
Yeah, I was just about to answer that typing, but unfortunately we cannot show how it links directly into NextGen EHR because that requires us to have the NextGen API suite installed in our demo for our demo environment, which we just do not have. But very exactly the same way that IMO is writing back into NextGen today is exactly how this same version will work. It will show back into all of your assessment grids within NextGen and then all of your problem list grids for any changes you make in the problem list using IMO Core.
Okay. Joe, I know you were just at NextGen UGM, but have you heard any feedback from clinicians or any coders about these workflows?
About the workflow we've shown today?
Yes.
Yeah, absolutely. Yes. We did partner with about 6 clients that have been testing it and providing us feedback. I will say everyone has given very, very positive feedback about the way we're actually launching the new version now because it, like I mentioned, it is launching as its own medical records template. So it's a pop-up that kind of stops you from being able to go out do anything else in NextGen. So you can now have IMO open and then still go move through other tabs in NextGen as well. And then another point that we've been getting feedback on is just the speed of the product and wanting to make sure that it actually is performing at its highest speed possible, which is great that now it is because of the different architecture that we've used to build it.
Okay. Will the current version still be supported, or is the new version a mandatory update?
Yeah, that's a great question. This is not a mandatory update. The current version that you're using today in NextGen is still supported.
Okay. Can you confirm if this version loads quickly if using API?
It has, yes, it does. It
Okay.
does. Mm-hmm.
Sorry, I'm just making sure I got everything. I think that might be it. I
did see a question, and I'll just say it verbally for those that didn't catch it. If you want to know more information, you can reach out to sales@imohealth.com, as you see here on this slide, and we can follow up and have a private conversation with your organization about how this works within your workflow.
Thanks, Deepak. All right. I just wanted to say thank you so much for everyone joining the call today. I know you have a lot of other places to be, so thank you again. I wanted to remind everyone that you can visit our website at imohealth.com/events. We always have at least 1 or 2 webinars a month. Next month is our annual CPT code set updates. So if that is applicable to your job, feel free to sign up. We'd love to have you. And then thank you to our lovely speakers, Joe and Deepak. Great work. And let us know if you need anything. Like Deepak said, sales@imohealth.com, and we'll get you to the right person. Thanks again. Bye.
Thanks, everyone. Bye.